Yep, we're recording. Okay. Hello. Who just arrived?
This is Sylvester. You're talking to me.
Hello, Sylvester.
Hello, everybody.
Hello, Sylvester.
Hello.
Number 3. Oh, you got him. And Len. Hello, Len.
Hello, Rick.
How are you?
I'm doing well, and yourself?
Good. Hey, that study I sent you was right on the money for you, wasn't it?
Kind of. There's a lot of some differences, but I mean, I would say it doesn't really change my plan,
No.
but just confirmation, I guess, that it's the right way to go.
And that that when you do resume, you should resume with abiraterone.
Yeah, definitely.
Yeah.
I left off with it. Why not resume with it?
Right. So let's see. We'll hang on a couple more minutes because the people are slow coming on today. But I'm sure they'll be here. Fortunately, yeah.
Is Jake on the call yet?
Yes, he is.
Yep. Hi, Len.
Oh, hey, Jake. So I don't know if
I was talking to you and Sylvester, and then I realized I had my mic muted. So hi.
Oh,
hi, Len.
hello.
Hi, Sylvester.
Hello.
Yeah, we need to agree on a time when we can talk to Ring Central Meetings on Thursday afternoon.
Okay. Did they call you back?
He's been emailing me. I thought he was copying you as well, but
I may have.
maybe not.
Any time Thursday is okay, just as long as it's later afternoon. Better. Yeah.
Right. Okay.
And did you guys see that email from me about the guy that you might want to speak to at GoToMeeting?
Yes, I did see that. Thank you.
Pleasure. Okay. So what I was going to say is I actually have some stuff prepared for today and some studies to talk about. And in case we don't have a big group, I made some notes about 6 things that came out of ASCO that I've been reading about. So we have plenty to discuss, but usually we never have time. So
I do see your emails, Len.
Okay.
And welcome to whoever just called in. Who's that?
Peter.
Hello, Peter.
Hi, Peter.
Hi. Is there much feedback on the phone? Because I'm sitting in a car in a parking lot.
No.
It's okay so far.
Okay.
There is a little bit. There is a little bit of feedback from.
I'll mute myself most of the time.
Yeah, we have the underwater sound.
Probably the. Yeah.
Well, that means it must be Peter in his outrigger canoe or on his paddleboard.
So I'm sitting in the parking lot of the world famous Mana Foods health food store in Paia.
Okay. All right. That's good. Is that before or after lunch?
This is lunch.
Okay, this is lunch. Okay.
You're living it up here, huh? You're living the high life.
Oh. You should have arranged to meet Appler down there. I
was gonna say, Peter, I'll meet you at Cafe Des Amis. It's got some of the prettiest waitresses you've ever seen.
Yes, and I'm right across the street from them. Are you here in Paia or are you down in Kihei?
No, we were there Sunday. It's a great cafe. Just kidding about the waitresses, but the food is fantastic there. Very affordable
Yes,
too.
I've been there. I've been there many times. Their outdoor part, yeah, it's really nice.
Good. I'll
Sorry-
meet you there.
sorry I
Diane
didn't
will
call
too.
you.
Love it.
Yeah, I didn't
That's
call you
okay.
back because okay.
Nope, no problem.
I was just down in Kihei this morning, getting Susan's mail and stuff.
Oh wow. Okay.
All right. Well, let's see. Is it 10 after? And it's 9 after, which is close enough for government work. We will get started. I see here's who I see on the call. I see Jay Hannum, John Appler, Dennis Correa, Les Shelderup, Sylvester Mann, Sierra, and Peter. Did I miss anybody? Okay.
Sylvester,
So,
you missed Sylvester, I think.
Les.
No, I heard him call my name.
Oh, he did?
I said
Okay.
Sylvester.
I'm sorry. All right, forgive me.
I did. Okay. Les, you and I have talked a lot, but I don't think, and I know you've been on the call, but I don't think you've ever spoken before. Can you? Are you in a place where you can speak? Is your system such that you can talk to us today? Okay. So you're just going to listen in. I would suggest to you, if you want to consider it, calling in. Even though I know you can't mute, I think you would do fine, and at least we get to hear you, and at least we get to discuss some of the issues and give you some of the recommendations that that we can make for you. So Les and I have been going back and forth a little bit, and he lives in central Illinois and is looking for some advice on recurrent disease, and we have a good group of people here. Peter's on, so it would be a great time, Les, if you can do it, to call in by phone. I know you can't mute, but we can probably live with that. So I'd encourage you to do it, and you can pull a Dennis on us, and you can call in and stay attached by the web as well. It does work. So if we see you coming in, if we see a phone call coming in, we'll check who it is. All right, let me run down this list and just see who would like to talk about what today. Jake, do you have anything you'd like to discuss?
Nothing about me, but I would like to ask if anyone has checked out our video recordings with the transcripts and ask them their opinions.
Okay, we can do that. We have time. John Appler, anything you'd like to talk about?
I'd love to hear about the research you followed up on, Rick, and more globally, like to know a spot that might track all that research, to follow all the drugs and trials. We have one on our site. I wonder if there's a better one that's more global. So if you'd comment about that too, that'd be great.
Okay. We can talk about that. Let's see. Oh, Paul Frieda is on. All right, let me have Paul Frieda at the bottom here. Dennis, anything you'd like to talk about today?
No, I don't need any time, Rick. Thanks.
Okay. Sylvester, anything you'd like to talk about?
No, thank you.
Okay. Peter, anything you'd like to talk about?
Yes, put me on the list. I have a subject I'd like to. I'm kind of wrestling with a little bit.
Okay. Paul Frieda, welcome. Anything you'd like to talk about today?
Yeah, just a quick question about Lupron and teeth dental problems.
Okay, we can certainly address that. Was that the question you didn't get to last week, or is that still out there too?
Yeah, I think that was my second question.
Okay. And Rich Jackson, welcome from Virginia Beach. How are you?
Doing well.
Good.
Have something to throw out. Just if you need a filler at the end.
No,
Quick question.
we may need a filler before the end. Okay. So here's the issue. I know that some of you don't stay the whole call. Would you like me to quickly run through these 6 points from 2018 ASCO before we go to individual issues? Or would you rather I did that at the end? I don't know how we do a consent. We don't have a poll on here, but what's the consensus?
Before would be great, Rick, for me.
Yeah, do it now.
It may provide additional discussion points.
Okay. All right. Well, I'll run through these. I don't know how clear they're going to be. Before I do that, I would like to address John Atler's point about how and where you gather information. Because I don't tend to, unless a study is really significant, I don't add it as a resource on the website, even though I bookmark most all of these things. And whilst my bookmarks are fairly well organized within each category, they're a jumble. And I have a lot of bookmarks, as you can imagine. So sometimes it's hard for me to find stuff later on that I've read, even if I'm in the right file drawer. I really rely, I guess, primarily on Mike Scott, Prostate Cancer International, that we've talked about before. Jake, maybe, or Len, maybe you could put that in the chat window, the URL for that. So that's a primary source. Medscape for me is another good source that I get daily. It isn't prostate cancer focused, although they do have a lot of good prostate cancer information. In fact, I just bookmarked one. It's right up here on my screen that came through today. Headline, and this will interest everybody on the call: $200,000 saved with first-line docetaxel for prostate cancer, which caught my eye. And I will put, since it's right up on the screen, I can put the URL in the window and I can send it out to everybody. Medscape, you have to sign up for, but it's free. And they do have good stuff. MedPage Today is another daily information source that I get. Stat is another one. And then I do get Euro Today. I know Len is not a big fan, but I kind of like it. It's a little bit more technical. The problem is that it's not always 100% correct. In other words, whilst their reporting is technical, sometimes there are errors in their reporting, but they're technical errors. So you have to be fairly astute. Like, for example, Professor Bill, who finds errors in what they reported on PARP inhibitors, but for me, it went right over my head. So, you know, I think some of that has to do with them hiring extra people for ASCO and you know, maybe the quality of their own knowledge, but whatever it is, I do find it a good site. I do like some of the videos and the interviews between Chuck Ryan Dan George earlier this week on a study, Dan George. So that was sort of helpful.
You're breaking up a bit, Rick.
Where else do I gather a lot of? Sorry, it's not me. It's my internet connection. Can you hear me okay now?
Right now, yeah.
Okay. So I'm afraid you're going to have to bear with me. There's not much I can do. This internet connection is bad. If it gets really bad, send me a note and I'll call in.
Okay.
But there's just not a heck of a lot I'm afraid I can do. So those are the sites. Did you guys hear me?
No, you're breaking up again.
No,
You better.
pretty bad. Both the video, audio is gone.
I think you'd better call in. Keep your video open, maybe,
Right.
but call in.
Okay. So can you hear me right now? If you can hear me right now, I asked if there's any sites that you or Jake or Peter or anyone else on the call would like to add to that list. No?
Not for me. If I had only one place I could go to, it would be New Prostate Cancer Info Link.
Yeah, I use a lot of the ones that you mentioned already, Rick. I've never tried STAT, S-T-A-T, I assume that is. I never checked that one, but the other ones I'm familiar with, and I do use them. And I sometimes link on the
Yes.
Facebook page.
Yeah, we can't hear anything, Rick.
So hold on 1 second, guys. Can you guys hear me? Can you keep talking a little bit, and I'll come in.
Can we, maybe we should go to our individual questions for a while until you get this resolved. Would that be an idea?
I think so.
Yeah.
I think we better.
I know it got worse when
Would you like to start, Peter?
Sure. Okay.
Oh, now you guys can hear me.
Yeah.
I don't understand.
you got feedback, Rick, from your mic.
Yeah, I know, and I'm muted.
You have two mics open, so it's feeding from the other.
Rick, what if I start by going to an individual question?
Well, I don't know why I've got two mics.
If you have your computer on and your cell phone, it's catching both and feeding back.
The computer mic is muted.
Okay, so this is not coming from me. Someone else is the feedback here. Because I just turned my telephone off. Can everybody hear me?
Yes, and the feedback is gone.
Yeah. So the feedback wasn't coming from me. I don't know. So let's just keep going. And yeah, I heard what you said about the individual questions. Let's just keep going along. Peter, what about what sites do you use for your research?
The ones mentioned, I get stuff from Euro Today and Euro Weekly and Oncology Weekly or whatever those things are. And I kind of glance at those, but sometimes they come in more faster than I could possibly look at them. But generally the above stuff, it comes to me all the time. And also, what's his name? Dardan, what's his name at the in California, who runs the US2 group, who sends out the news you can use type of stuff. I find that really useful.
Yeah, I'm not on his list. So, all right, so let me go forward with these studies that I came across, and then we'll move on. And I want to just welcome Jeff Ledoux. I see you're on, Jeff. I'm sure that you would like to give us an update, so I'll put you on there to visit with you as soon as we get done.
And Larry
Rick, can you
Fish
hear
has
me?
joined too. Larry Fish is here too, Rick.
Okay.
Rick, can you hear me?
Yes, I can, Les. We can
Okay.
now.
Yeah, this is a new system, and I'm not certain if I can know how to run it or if it's working right. So I was just trying it.
Okay. Well, right now you're doing great. So
Okay.
we will come back to you.
Okay, I'll mute it then. Okay.
Okay. Thank you. Okay. So the first study, and this is one that maybe I'm going to just ask Len very quickly to comment on, was the use of abiraterone and Lupron together with intermittent androgen deprivation therapy. And the bottom line was that it appeared to be more effective on recurrence to add the abiraterone with the Lupron than Lupron alone. Do you want to say anything about that, Len?
I'm not sure there's anything more to be said about it. You just encapsulated it right there. Abiraterone or Zytiga plus Lupron appears to be superior to Lupron alone for guys on intermittent therapy, which probably isn't a big surprise because we know that it's true for guys on continual therapy also.
Right. The reason I asked Len to say something is because that's what he did. Correct?
Yes. Yes.
Yes.
Now, yeah, I've been 15 months now on drug holiday. I'm not sure if, what role Zytiga played in that, but may very well have been a factor.
I mean, what the research in this study showed was that men got 28 months of PSA-free survival with abiraterone and Lupron versus 21 months with Lupron alone. There was almost no difference in the time it took for their testosterone to recover back to the baseline, 13.1 months versus 12.9 months. So, I mean, it's almost identical. And the PSA relapse after testosterone was obviously a little longer if you were on abiraterone and Lupron than on the Lupron alone. But the bottom line is there may be some sense to add abiraterone, and Len is in that sweet spot. So that was the first major takeaway. Second major takeaway, which was Dan George's study that I heard Dan George talking about with Chuck Ryan, was that African Americans respond a lot better to abiraterone, evidently, than Caucasians. And they don't know why, but these are observations that are coming out of a study that Duke is heading, Dan George in particular, but it's a multi-centered study, includes New Orleans, and I can't remember where else. That one sticks in my mind. There are about 4 different centers. Oh, maybe Birmingham, Alabama, New Orleans, and somewhere else, St. Louis maybe. But anyway, that was another take home from ASCO. Third take home from ASCO was that even if you are ARV7 negative, it does not necessarily mean that you will respond well to abiraterone or enzalutamide, because they've kind of determined that some men, even though they're ARV7 negative, as soon as they take abiraterone or enzalutamide, their ARV7 turns positive. So just because you're ARV7 negative, you shouldn't assume that you'll do well on abiraterone or enzalutamide. It depends on the individual. The next take-home point, number 3, was an interesting one. They showed that for high-risk men going into initial treatment, there was no advantage to adding chemotherapy immediately after the radiation. And this is one that's kind of near and dear to my heart, because I even 11 years ago, when I went through treatment, I remember talking at some length to a couple of doctors, including my urologist, and saying, look, is it worthwhile doing chemo up front? And even at that time, they said that the studies just don't support it. And there was a poster at ASCO that said adjuvant chemotherapy after radiation for high-risk men shows no advantage. That was the 4th point. The 5th point is about gallium-68. And let me just see. I think this was just that gallium-68 was confirmed as being a very good screen to detect lesions. Although it was confirmed that it's a very good screen to detect lesions. I have some proviso here with respect to salvage radiation, and I honestly cannot tell you what that is. I need to go back and look myself. But anyway, I think we know gallium-68 works well, both as a, well, gallium-68 works well. And the last one, which I may ask Len to handle because I know he's read it, has to do with adding abiraterone to olaparib, which was a study that was that I think Len saw, and then it was reported on Euro Today. And my notes say that it is very effective on recurrence, and you got 5 months of extra radiographic-free progress, although only 2 months of overall survival difference. I think this was specifically for men that had done olaparib, got something out of it, and then maybe it stopped working, and then the idea was that if your PSA started to rise again, it was good to add abiraterone to the olaparib. Is that right, Len?
Yeah, I'm afraid my memory is as fuzzy as yours, Rick. All I can recall was, because it struck me as being odd, was that if you added abiraterone to olaparib or vice versa, as you said, progression-free survival was extended, and it didn't matter if the patient had any DDR or DNA damage repair mutation or not. And previously, we learned, or we were told, that olaparib is only useful for those with some sort of DNA damage repair mutation. So for some reason, you combine it with abiraterone, and now it didn't matter if you had a mutation or not. It was more effective. I don't know what to make of that. I had posed that question to Bill, Professor Bill, but I guess he's just too busy. He didn't get back to us on that.
So if you want more, I mean, I'm sorry that some of these summaries are a little flaky, but really they're just designed to whet your appetite. And if you want to find out more, you can Google. So for example, on this olaparib study, just put in abiraterone, olaparib, ASCO 2018, and I'm sure you'll get something up. I know that I've got an email from Euro today that hits on all of these, and you can learn more. Same thing on that gallium-68 and any of the others. So I don't want to take a whole heck of a lot more time, because we want to visit with Les, and then we've got plenty of people in the second hour who have things that they might want to talk about today. Let me just check and see. I'll tell you who I see on the call right now.
Rick, I just put a link to that to a Medscape article on the olaparib that you were discussing. I just put a link to it in the chat box.
Thanks a million. Yeah. I'll look at that afterwards. Thank you. So here are the people I see on the call. I'm not sure if John Appler's still with us or not.
Yes, I am.
Oh, you are. Fine. Okay. So we've got Jake, John Appler, Dennis Correa, Les Shelderup, Sylvester Mann, Len Sierra, Peter Cathfield, Paul Frieda, Rich Jackson, Jeff Ledoux, and Larry Fish. Did I miss anybody? And Larry Fish, would you? I don't see Larry on here. Oh, yes, I do.
I'm here.
Larry, would you like any time to talk about anything today?
No, I'm okay today, thanks.
Okay. All right. So let's kick off with Les. Les, unmute. Speak up.
Okay.
Tell the guys a little bit about your situation, how old you are, where you're being treated, what your issues are, and then pose the questions you pose to me, and we'll see what answers we can come up with, or guidance we can come up with for you.
Okay. Can you hear me okay now?
We can.
Okay. All right. Well, I'm 74 years old. I was diagnosed a little over 5 years ago with Gleason 10. Prostate cancer it had gone up very quickly. And within 9 months, it went from normal up to 24.8 for the PSA. Had already gone to the seminal vesicles, so they had assumed it was spread, but they could not find it, detect it in what equipment they had in the rest of the body. Anyway, I was put on hormone treatment and immediately radiation, external beam radiation. And I was on hormone treatment for about 2 years. This was all local around near Moline, Illinois. Then I went in November of 2014. I went to Mayo Clinic with Dr. Eugene Kwan. He took me off of the hormone treatment and kept checking me on this C11 choline PET scan to see where the cancer was going. In February 2017, Mayo removed 33 lymph nodes, 18 of which were malignant. January of this year, Mayo did a cryoablation, freezing 2 malignant spots on my spine, and was also started on Lupron. Each time the cancer gets loose, let's say, the PSA increases rapidly, something like 6 weeks on the doubling time. And it's gone up to about 4.8 is the highest they've seen before they had shut it down again. Anyway, the situation is now they're recommending, they being at the Mayo Clinic, recommending going to additional radiation treatment of the pelvic lymph nodes. And anything I've ever heard before and from everywhere else is that once you've done radiation, you do not do radiation again. Like I say, I've talked to a few other doctors locally, and there's one Dr. Luke Nordquist from Omaha that is a little better known, and he recommended against doing any more radiation too. So I'm hearing from supposed experts and getting very contradictory information, and I'm really in a quandary right now.
So the first question I think I have for you, and I think I asked you this in the email, is when they did the original radiation, what was the radiation field that they addressed?
Well, only as far as I know, I was just told it was the seminal vesicles along with the prostate.
Okay.
And that's as far as I know. I didn't hear anything else.
So it would be really helpful for you and your doctors if you contacted your original radiation oncologist and asked him for your report, your radiation report, because in there it will specifically indicate what they radiated.
Well, what are the other choices?
The other choices are, as many of us have had, is that they radiate the whole pelvic girdle.
Oh,
meaning
as far as I know, no. All I was told that that it was just confined to the prostate and the seminal vesicles. Now, I did have them send the entire map to Mayo Clinic, so Mayo Clinic has seen specifically where they have radiated.
Mm-hmm.
So,
well, and
go ahead.
Did you share that map with Dr. Nordquist?
No.
So here would be my concern. If Dr. Nordquist was unaware that let me step back one. For men who have the type of disease that you have, most centers of excellence, and I know that's a term that's not familiar to you, so I will explain it momentarily.
Okay.
Most centers of excellence will radiate the prostate bed, the seminal vesicles, and the pelvic girdle. That has pretty much been standard of care now for several years. And so Dr. Nordquist might reasonably have assumed that with a Gleason 10 and seminal vesicle invasion, your pelvic girdle was radiated, and he didn't see any information otherwise. And if your pelvic girdle was already radiated, it's probably not advisable. I mean, we're not medical doctors, and we can't give you advice, but just from experience, if it's been radiated once, rarely is it radiated a second time. If your pelvic girdle has never been radiated, then there's good reason to radiate it. In fact, if it were me personally, I don't think I would have gone through the lymphodectomies and the cryoablation, but probably would have opted for pelvic girdle radiation 2 or 3 years ago, because we know from the studies that have been done that that offers very good and positive results. So the reason why I'm personally am honing in on the extent of that radiation field and trying to understand Luke Nordquist, who I think is a great doctor, by the way, is that I suspect he thought your pelvic girdle had been radiated, and in fact it never has been. And if it has not been, then yes, you probably are a candidate right now for additional radiation.
Okay, if I may.
Can I just explain centers of excellence for you?
Okay, yes, please.
So centers of excellence tend to be academic centers where other medical professionals are trained, and that they are usually affiliated with national groups like the NCCA, which is the NCCN, which is the National Cancer Center Network, of which there are 40 affiliated hospitals, or NCI, which is the National Cancer Institute, or affiliated with the NIH. But it's a marker of good care, where very often the research that's done is shared amongst those hospitals. And some hospitals have more than one accreditation. So you can be an NCI and an NCCN hospital. So let me just ask the guys, is there anything else any of you would add to the explanation of Center of Excellence? Okay.
If I could ask a question on that.
Absolutely.
I know generically what it would mean. I didn't know if there was some list somewhere when you asked about if I had some communication with them. I didn't know if there was anything specific you were referring to. You know, I don't have a list of hospitals that are on that would be considered on the Center of Excellence.
Mm-hmm. So I'm sorry, you actually faded out right at the beginning and then you came back strong. But you say that when you spoke to your insurance, you don't have a list of those hospitals?
Well, I didn't talk to the insurance, but I do not have such a list.
Okay.
So I didn't, you know, I would assume that like the Mayo Clinic should be on some of those lists, but
yes, it is.
I didn't know when you asked about having contact with others. Yep. I didn't know what others would be on the list.
Okay, so for example, in your region, there are hospitals in Chicago that would be on the list, like University of Chicago and Northwestern. Probably in St. Louis, the hospital there would I've just lost the name of it, but the cancer hospital there would be on the list. Minneapolis, there would be hospitals. I mean, those are the ones that come immediately to mind.
Do you know if there's one in Iowa City?
Probably not.
Okay.
Not that I'm familiar with. You know, I mean, but let me, before we go further, if your concern is whether you should get additional radiation or not, which seems to be the question there, and where you should get that radiation, let me throw it open to some of the guys on the who are on the line. Peter, I mean, what are your thoughts on how Les want to proceed?
Well, this is the exact topic I want to bring up. So I'd rather not comment at this time and bring it up in mine, which is a little bit different. So I don't have a comment in this because I'm struggling with the same thing.
Can we bring you in with your issue to merge the two issues? Is that possible?
I don't know if there's a little the shades of difference in mine.
Okay.
I guess I do have a question for Les. So when you talked about removing lymph nodes and having cryotherapy, were all these lymph nodes in the prostate bed, or were some of them in the abdominal area as well, and did they do both?
Well, they were in both sides of you know, in that pelvic area.
So above your iliac crest in the abdominal area, or down in the pelvic in the prostate bed?
I would guess in the prostate bed.
Okay, that answers my question. Thank you.
One other comment, Rick.
Yes.
It is possible that Luke Nordquist did know, because he had requested the information from the Mayo Clinic be sent to him. So it is possible that the information that was transferred from the local Moline to the Mayo Clinic also got transferred on to Luke Nordquist. I don't know.
Again, one area that I think I would like to, Peter, could you mute? Please, thank you. One area that I would like to get into a little more is knowing better where your lesions are right now. So if we are comfortable that there is no metastasis beyond the pelvic area, then that might be an important factor in deciding whether you have additional radiation or not, notwithstanding whether it's been radiated before or not, or previously. But if, for example, God forbid, there were lots of lesions up and down your spine, that might change the equation. So, you know, one of the things that might be important for you right now is to get a more accurate scan. Is that something that anybody has talked to you about?
Well, at the Mayo Clinic, they've done this C11 choline PET scan, and they claim that that's, you know, very good. I know you had commented there may be others now, and I've heard of others, but of course they think theirs is the best in the West.
As always. Well, there are others that are better. I mean, there's no question. I mean, you heard me mention this gallium-68 scan that we talked about at the beginning of the conversation is certainly a better scan. There's something even better than the gallium scan, we think. And, you know, the scan that's readily available across the country in many different locations and would almost certainly be covered by your insurance is the Axumin scan, which would highlight do a better job highlighting where those lesions are. At the same time, Dr. Kwan feels he's an expert with that C11. So does Dr. Almeida in Phoenix. And 3 months ago, 4 months ago, Dr. Almeida was telling patients that there was nothing better than him reading a C11 scan. And yet right now, Dr. Almeida is doing tests with the gallium-68, So, you know, what happens is these guys say everything is the best if they think they're the best person with that scan, but in practice, the technology is probably better than the individual. Not that they wouldn't add something or interpret slightly differently, but my money would be on the technology rather than the individual for something like scan. Out to the people we have on the call to see what sort of comments they may have, if any, for you, Les. Anybody want to say anything?
I would, Rick. We may get. We're getting feedback from somebody. Okay. Anyway, 20. We may get a hint as to what type of radiation he had if we know how many sessions he had. So probably typically the prostate and prostate bed alone would be maybe 25, 28, whereas full pelvic girdle would certainly be at least 40 or more. Do you know how many radiation sessions you had, Les?
Yes, I had 42.
Yeah, I suspect he did have pelvic girdle then.
Yep. Sounds like you probably did have pelvic girdle.
Yeah.
Absolutely.
In which case you would not want to do it again.
Right. Good call. Good call.
But I mean, you still should verify it with your doctor just to be sure.
Yeah. In that case, I would find it strange that Mayo is suggesting more radiation. I would have to agree with Dr. Nordstrom, because it is a little weird if you already had pelvic girdle for them to radiate it a second time, Les.
Yes, the problem is, of course, Dr. Kwan said, well, Mayo Clinic, we can do it. And that's what I've run into. I've run into that with other things with doctors that I'm better than everybody else.
Yeah, we hear you. We hear you. We don't have any Mayo Clinic, anybody on the call today with Mayo Clinic experience, I don't think. We do have people quite often, but not today.
Rick, it's Dennis. My experience was at the Mayo Clinic here in Phoenix, the new facility.
Right.
And I'm not sure about when they inquired about the scans, but like you said, I think they've changed fairly recently. And, you know, I had that Acumen scan, and when I initially contacted them, I was talking about the choline scan being, I thought, was the most up to date. And they said, no, they have this new Acumen scan. And that's what I had, and that found my progression into the sacrum and my left femur.
And did you do that Acumen scan at Mayo in Phoenix?
Yes, I did.
Okay. You know, it sounds to me less like you're sort of running into the Gene Kwan factor here. And probably if I was in your shoes, I would want to get second opinions. And I definitely would want to get an Acumen scan as a minimum. And if I could find or access a gallium-68 scan locally without having to travel too far, I would want to do that. By the way, you can get an Axiom scan right now at no cost through a trial that Almeida is running in Phoenix, but of course you've got the expense of getting to Phoenix and coming back from Phoenix. But I think if it were me, I probably would go to either Walter Stadler at University of Chicago. I would say three. I would get three choices. I would either stick with Luke Nordquist, who I think is very good. He himself is not at a center of excellence, but he's trained at a center of excellence. He trained at Memorial Sloan Kettering, and I think he's very, very good. And I would either stick with him, and I'm sure you can find an Acumen scan through him, or I would go to Walter Stadler in Chicago, at University of Chicago, or I would go to Alicia Morgans. Alicia is Alicia, Alicia Morgans, Morgans, who's at Northwestern. I think those would be my three choices. Les, what did Dr. Nordquist suggest?
He suggested going with let's see, Zytiga with prednisone.
Okay.
Athena and her fiance into the apartment here in return for rent for taking care of me.
Can
Back.
we
Eric?
mute? Yeah,
Eric, welcome to the call, but can you mute yourself for the moment?
Thanks. Okay, so you know, certainly there's a lot of value, proven value, to considering Zytiga right now, and we'll revert to that. We're going to spend about another 5 minutes with you, and then I think we have to go on. But I would like for you to hear a little bit from the guys that are on Zytiga. I think probably an Acumen scan to get a better handle on where all of these lesions are, and then some sort of systemic treatment does make sense, whether it is whether it's a second-line anti-androgen like Zytiga or enzalutamide, or whether it is chemotherapy is really something you and your doctor need to discuss. But let me ask the guys on the call who have done Zytiga or are currently doing Zytiga, what Les might expect from adding Zytiga to his treatment, to the Lupron that he's currently doing. Len, do you want to kick off with that since you've added Zytiga to Lupron?
Yeah, and then we should hear from Peter, who's had maybe a little more experience with it. So when I had Zytiga added to Lupron, I really didn't notice that much of a difference. So if you're tolerating Lupron fairly well, you'll probably tolerate the combination just about as well. You may have a little more fatigue, but otherwise, I think most guys say they feel pretty good on Zytiga, possibly because some attribute it to the prednisone, which can elevate your mood a little bit and maybe get rid of some arthritic pains you may have. Yeah, I think I'll turn it over to Peter. Oh, just one other thing, Les. In the chat box, I did put in a link to the list of the NCCN hospitals. I don't know if you're on the computer or the phone, but.
Peter, would you like to Peter, would you like to talk a little bit about adding Zytiga to Lupron?
Sure. I've been on Zytiga and Lupron for 3 months now, and I'm doing well with it. And the Zytiga within the first 2 weeks got rid of my PSA doubling. You know, my PSA went down significantly, and it's been staying down there. So, because my disease was similar to yours, recurrent in lymph nodes. Yeah, I think at this point with a Gleason 10, I think you need to get a really good genitourinary medical oncologist who you really can work with, because I suspect that, I don't think you're going to do radiation at this point. I think you're going to probably want to do, drug therapies to keep things under control. So that's what I would do at this point. Make sure you have someone you can work with.
Okay, the thing is, I had assumed from everyone around here that Dr. Kwan was it from this general area, region of the country. People are always talking about Dr. Kwan. He's the one to go to. And now I and some others have been questioning it a little bit. So I'm a little bit leery going away from him, since he was supposedly the guy to go to.
Yeah, well, if you would have asked me personally, I mean, opinions are like, as they say, opinions are like arseholes. Everybody has one. I would never have sent you to Dr. Kwan because I'm not a fan, although we have guys on this call who have done very well by him. First of all, Dr. Kwan is not a trained medical oncologist. He's a surgical oncologist. He trained as a surgeon. He didn't train in internal medicine. And whilst he likes to practice internal medicine, for me, he's not the right guy. And even though I know he does very well and he's very amiable and he's got a good manner with his patients, he would not be my personal first choice, although some people really have done exceptionally well. I mean, Brian Heisey isn't on the call today, but Brian had remarkable success with him, and Brian lives in Chicago. I would go to, as Peter said, I'd go to a medical oncologist. I think both Peter and I were very impressed with Luke Nordquist when we heard him speak at PCRI last year. I don't think you can do a lot better. He's definitely has a specialty in genitourinary disease. He knows his stuff. He's excellent. And the same would be true of the other two names that I gave you in Chicago, Alicia Morgans and Walter Stadler. I mean, I think any of those three names are good. And I think it's probably time to switch your care from Kwan to one of those three medical oncologists.
Okay, as far as Dr. Norquist, how I was introduced to him was through a CD or a DVD from that Prostate Cancer Research Institute seminar also. So it was from that same seminar meeting that I got his name.
Okay, well, I mean, he is very good. I don't want to exclude Dennis. Dennis, you have the Zytiga Lupron badge, and similar experience. What would you like to add to the conversation?
Well, I have to agree with Lynn. After being on the Lupron for so long, and then I had my progression and started on the Zytiga with the prednisone. Not a whole lot of difference, maybe a little more fatigue. And for me, getting the stuff that prednisone, I couldn't think of it. Prednisone helped with my arthritic stuff for sure.
Right.
So other than that, not much to add. But just listening to all the conversation here, I think he's taking the right steps. Seriously think about the second opinion, and absolutely the medical oncologist part of this thing, and getting a very latest type of a scan done. That's what really worked for me when I was my PSA was starting to go up and up, and my doc was telling me there was no problem. I said, well, I think I need another opinion, which I did get, and also got the scan, got on the Zytiga, and so far so good.
So Les, I'd like to move on because I want to allow time for some of the other people on the call.
Absolutely.
but I hope that this has been very helpful to you. I hope you've gotten some names, you've got a better feeling for centers of excellence, for the types of treatment. I think we've sort of clarified, and Len's very astute question as to how many radiation treatments you had certainly clears up the fact that you must have gotten pelvic girdle radiation, full radiation. And on that basis, it is a little beyond me and certainly beyond Dr. Nordquist why they would be offering you more. That would give me some concern. If I were in your shoes, I'd probably be seeking to switch my care at this point in time. I would say I'd gone about as far as I could go at Mayo, and I would want to be sure I moved my care to a really top-notch medical oncologist, and you have 3 good names there. And, you know, we hope you'll keep coming back. Now that you can talk to us, which is a pleasure, we would love to have you back, and you can ask questions anytime and have the floor anytime and bounce ideas off us anytime, and, you know, just join the club.
Okay, very good. And I certainly appreciate all your comments from everyone. That has been very helpful. It certainly is appreciated.
Good, good. Well, you are on the list. Keep on coming back. Okay, I'm going to move on to Peter. Peter, why don't you talk to us about your concerns right now, which maybe mirror a little bit Les's concerns. Hold on, let me unmute you. Oh, there you go. You should be, go ahead, Peter. No, somebody, no, try. Okay, try now.
Okay, so my situation is considerably different than Les's. I've got what would be considered oligometastatic disease. In other words, 5 or less. I've actually got 2 metastatic lymph nodes. And this is where Eugene Kwan's expertise really is in oligometastatic disease, but as opposed to extensive disease, which we just considered with Les. Anyway, so I'm torn between. I've gone to 2 different places for consultation on additional radiation, and my lymph nodes that have lit up are north of my previous radiation field. They're above my pelvic girdle, just above in the abdominal area. I've got one on either side of my pelvis up there. So at this point, I've got things under control. I'm not panicking or anything because I'm on Lupron and Zytiga, and things seem to be stable so far. I've consulted with a radiation oncologist at UCSF, and their comment was they feel they can do this with maybe 3 or 5 stereotactic body radiation zaps. And I also consulted with Dr. Carl Rossi down in San Diego at California Proton Center. And he kind of said that his approach was, well, if we're in there, we should do 25 sessions. Proton beam is a little different but it's still radiation. It goes to the area rather than through it. And his reasoning was that all the lymph nodes are interconnected, and I probably have systemic disease, and I probably should enlarge the radiation field. So a couple of things, in my research and thinking come to mind. One is that I know that the California Proton Center is bankrupt, as many of the proton centers around the country are, because they're so expensive and overbuilt, and they don't have the people to get that radiation, enough clients. So I'm wondering if I'm being sold too much radiation, whether 25 doses is over the top, because I was hoping that we could just do stereotactic proton beam, pencil beam radiation. So that's one thing I'm concerned about. The other is how much radiation is as Les just said, how much radiation do I warrant in my body? I've already had 39 sessions of IMRT. How much more can I take, even though it's not in the same field? Even though it would be in a different field, is it safe to really do much radiation, or should I just handle this with systemic drugs and possibly do chemo at some point, rather than get all geared up thinking I can get rid of this stuff, get rid of these 2 spots. So that's where my dilemma is, and I'm not asking you. I'm asking opinions. I'm going to consult with my oncologist next month on this. He's well aware of where I've been consulting and so forth. And I'm not in a panic, but as all of us know, every step along this journey, you reach these decision points where you wonder which branch is going to hold my weight. Do I jump up to the branch on the left, or do I jump up on the branch on the right? So that's where I am in this.
Okay. So who would like to respond to Peter? Who's stepped in these shoes before, or would like to give Peter your 2 cents?
I have an opinion on this. Peter, Len, I would recommend that you somehow contact, email, or his blog or whatever, Alan Adele. I believe he was the one who noted that spot radiation is not really very effective. So definitely consult with him. That's free. The other issue about proton beam, it's very interesting that you mentioned proton beam centers that are going bankrupt, because in my local prostate cancer support group, there's a guy who's just an insanely rabid advocate for proton beam, and he keeps claiming that they're opening up more and more all over the country. And then on the other hand, I've heard, as you mentioned, that a lot of them are going bankrupt, or they're simply closing up shop, including, I think, the one at Loma Linda in California, where I believe it all started. But have you heard anything about these proton beam centers expanding?
Well, I know some of the big places in the East. I know there's a place in Virginia. I know there's several in Florida. I know that a couple of years ago it was a big move, and a number of places built, but some of them never opened because of the financial issues. The fact that people weren't flooding to proton beam. I mean, I agree with you. Some people who've had it just rave about it. It's like a cult, but
yeah.
But they don't have enough. It's never been proven to be as effective or better than regular radiation, and it's just a lot of these places just aren't floating.
Right. Theoretically, it sounds like it should be at least as effective with fewer side effects, but I believe there are no statistics to back that up.
No, there's good.
Correct.
There's good science to back it up. It's just that.
Yeah, theoretical science, but
there's no. I worked in the Berkeley labs, and we worked with Loma Linda, and the ions definitely give up their energy at a certain spot, so you get less damage to the benign tissue, and so there's no question about that. What people refer to when they say it's no better is that they haven't been able to establish that survival rates are greater, and so they say, oh well, there's no, it's 4 times more expensive, but there's no clear improvement in survival. So so that's probably true. Apparently no one's been able to prove that you get better survival. But as far as the science goes, there's no question that the proton beam is more accurate than just standard radiation.
Well, I would say something different to that, Paul. I think that what we haven't been able to show in trials is that proton beam has lesser side effects overall, comorbidities, than standard radiation, and that's the issue. This isn't an overall survival issue, in my opinion. This is an issue of which one has the least amount of side effects? Are you paying a heck of a lot more money, but you're basically faced with the same side effects? Now, there is a head-to-head trial going on right now that hasn't reported, and there was a trial, a small trial done. I think I've sent that to you before, which showed that the standard beam had more rectal and anal side effects, and that proton beam had more abdominal and gastrointestinal side effects.
Oh, okay.
And so, you know, it's 6 of one and half a dozen of the other, and that's what that showed. But I think I want to bring this back more, not to the proton beam, but the standard beam. I want to bring it back to Peter's dilemma, which is, and I really, what Len said, great point. Are we playing whack-a-mole when we start doing spot radiation? Anybody who, I know Eric was on the call, but Eric he's not on the call right now. I mean, nobody that I know who's been in these groups for years has had more spot radiation than Eric. Is there anybody on the call right now who has had spot radiation?
I have. This is Bill Burns.
Go ahead, Bill. Bill, what's your, to what extent do you think spot radiation is a game of whack-a-mole?
It depends on what the objective is. In my case, it was to limit the pain coming from 2 different lesions, one in my spine and one in a rib. And it did reduce, the pain went away, and it's never come back. But in terms of a therapeutic strategy to stop progression, I don't think it works.
Thank you. Peter, do you want to respond?
Yeah, that's my thinking. If the spots were on my bone and I had pain associated with it, I would probably go that way. But I agree. I mean, that's why I'm seriously thinking of just sticking, seeing if how long the Zytiga and Lupron will work, and maybe eventually go into chemo or something. I'm just suspicious of zapping lymph nodes, because I know the whole lymphatic system is interconnected, and it's just a matter of time before it shows up someplace else. So that's my thinking anyway.
Yeah, and my oncologists have said basically the same thing, that it's palliative, but that's about it.
Yeah, and Peter, Dominic went down to Daptoli Center down in Sarasota after full pelvic girdle radiation, and he had his retroperitoneal area, like similar to yours, above the pelvic region, radiated, and that wasn't spot radiation. It was like 40 sessions, and did absolutely nothing for him. His PSA didn't drop even a tenth. In fact, I think it went up a little bit, and he kind of regretted having gone down there. You remember that, Rick?
I do, and I always remember. I remember a consult I attended with a friend who, early in his metastasized disease, when he was still oligometastatic, visited with Chuck Ryan, and Chuck Ryan said at the time, try spot radiation, but the likelihood that it's going to contain the disease is less than 10%. So that was the expectation that Chuck was setting up. And this was 9 years ago, 8 years ago. So anyway, Peter, we need to move on.
Go ahead. But thank you.
But I hope that this has been helpful to you, and we can talk about this again. Never hesitate to bring it up with different people on the line, and you know, one time when Eric is on the line, it would be really good to ask him. So I'm going to go on to Paul Frieda, and Paul, you had a question about Lupron and dental issues. Was that right?
Yeah, yeah. I'm just wondering if anybody's correlated those two, or what, or is, well, you know, what the things I'm having with my teeth have nothing to do with it.
Well, I mean, I certainly am not aware, I know I've never looked on excuse me, not on clinicaltrials.gov, on the research sites for anything specific. I mean, we know that there's a strong association with the bone strengtheners like the bisphosphonates with dental issues. But does anybody have any feedback on LHRH? I mean, the only thing I can say to you is that what we do know is that that you lose bone strength when you're on extended Lupron, and that should probably have some relevance to your teeth, but I don't know what's been shown. Anybody have any information on that?
I've never heard of a connection being made between the two. Number one. And number two, I've been on Lupron, so Eligard rather than Lupron, but the same drug for going on 5.5 years now. And I have, which is a long time, I think, compared to many other patients, and I've never had an issue.
Right. Mm-hmm. Okay. All right. I'm just wondering if some people had some experience with that or had heard anything.
Well, so what is a specific issue that you're dealing with?
Oh, I occasionally get some pain in my upper left jaw, and it's just about ready to drive me to the dentist and ask for X-rays, but it's not been consistent enough that I can say that I that I have to do that. But it comes in conjunction with my consideration of going on a Lupron holiday, and if it was correlated, that would give me more incentive to go on the Lupron holiday.
Yeah, I mean, if I were in your place, I think I'd try to get a more definitive answer from someone who has more expertise than I do.
Right.
But
well,
I haven't heard of that connection.
Yeah. Okay. I actually haven't gone out to the PCA websites and asked the question. Then there hundreds and hundreds of people would see it, and someone who knows, someone who's had some experience might respond. So.
Right.
Have you looked on PubMed or Google Scholar and seen if there's any
Google Scholar and PubMed?
Yeah.
No, I haven't. PubMed and Google Scholar.
Right. So here's something I would recommend. If you haven't done it, all of you should do. I gave a talk at PCRI last year on how best to use the internet for your research. And at the time, I think we publicized it. And if you go to our YouTube channel, it annoys me intensely, Mr. Hannum, but it pops up right away, which I'm not very happy about. I don't know how to stop it popping up. But
why are you happy about that?
I beg your pardon?
Why are you unhappy that it pops up like on YouTube? The ANCAN site.
Because my talk doesn't need to be the focus of what's on our YouTube channel. But
it just no matter what you go to look at, his video just shows up as first.
Is that right?
Yeah.
Yeah, I don't know why. Maybe Jake can figure it out. But anyway, as it so happens, it's perfect for you. Because I want you to go there and I want you to watch that video. There will be a quiz.
Oh, okay.
Okay?
Right.
You're
Okay.
a school teacher, you know what that means. And I want you to make notes because it bothers me when we get people like you who have been on the school for such a long time and sites like PubMed and Google Scholar are new to you. They should not be. These are great sites.
What was that last one?
The Google Scholar.
Oh, I thought you said one after that. Okay.
No, I just said PubMed and Google Scholar, but there are loads and loads of resources on that site. I probably should have mentioned that when at the beginning when we were talking, when John Appler asked me about where do I get my information. I forgot about it, but yes, watch that hour presentation. Actually, the presentation is probably about 40 minutes, and then there's about 20 minutes of questions.
Right, right.
And then come back to me with pleasure and ask me if you ask me any questions on that. But I think everybody will find it quite helpful. You know, I used that, I highlighted that in a recent letter to you all. It's so important that you guys do your own research.
Right.
And then if you can't find what you need, come to us. We will help you with pleasure. But try and do your own research. And this is a really good one. I don't know much about Lupron and dental issues, but I do know where I'd look. And you know, you're a scientist, Paul. I'm sure that you could probably find some good stuff on that.
Okay.
Yes.
So I would recommend doing the search using the word Luprolide rather than Lupron, because that's a broader description of, you know, Lupron is Luprolide, but then there's Eligard, which the other half of the prostate cancer world is treated with. And so you want to see if there's a connection to Luprolide rather than just Lupron.
Okay.
I just did a
go further than that, Bill. I think what I would search for would be LHRH drugs and dental issues, teeth, because there's not just there's Eligard, there's Trelstar, there's Zoladex, there's Lupron. Yeah, there are so many different brand names, and so I wouldn't just pick out, and I wouldn't pick out just say Luprolide. I think I would use LHRH as the category. What do you think?
Well, then you're going to start picking up things that are not really relevant. I mean, if Luprolide, so is it Paul? Are you the one that had this issue? Who?
Yeah, Paul.
Yeah. I mean, if you're taking Luprolide, which you are, if you're being treated with Lupron,
right.
I think I would at least start there. But if you don't find much, then yeah, it might be a good idea to follow Rick's advice. I just did a search at PubMed on Luprolide and dental, and it turned up 7 papers.
Oh, really?
Yeah, and that's very few, and none of them really look relevant. So I think, you know, that sort of matches my experience in not, you know, encountering a connection between these two in the past.
Okay.
But I'm not certain. I mean, I'd have to look at the abstract for each one of these papers. But it looks like they're dealing with other issues other than a problem with dentition, for example.
Okay, I'm going to jump in, and I want to move along. But Paul, I think you've got a few things you can follow up with there.
Absolutely.
Discussion, because we got some good stuff out of it.
Okay, thank you very much.
Pleasure. Rich Jackson, you left and you came back. I'm pleased to see, because you have the floor.
Perfect timing.
Yeah.
I just switched from Lupron to Eligard. I know they're chemically basically identical, but has anybody bumped into any additional increased side effects, decreased side effects from going from one to the other?
Professor Bill.
I have not gone from one to, I've always been treated with either Eligard or Firmagon,
Okay.
the garlics. I started out with the garlics and then lost the battle with my oncologist to stay with it and was switched to Eligard. The drugs are identical. Leuprolide is Leuprolide, and the difference is in the vehicle that's used to deliver the drug over a long period of time. So it's packaged into some sort of matrix that's injected into you. And Leuprolide is generally injected into subcutaneous fat in the belly. Eligard. And Lupron, I think you guys that get Lupron are usually getting it in the fanning. Is that right? Yeah.
I did. Yeah.
Yeah,
So
it's intermuscular glutinous.
there might be a
Or
difference
shoulder. I get it in
Okay.
my shoulder.
Yeah, that's right. So there might be a difference in the length of time it takes for the drug to leach out into your circulatory system, but the drug is the exact same drug in both cases. And so, I would expect that there wouldn't be different side effects for one compared to the other. Perhaps in terms of injection site issues, inflammation, but other than that, I would not expect that there would be. And that's I'm pretty confident of that.
This is I was the other way around. I was on Eligard for 2 years and now recently switched to Lupron. And the only thing that I've noticed, I believe, is I'm a little bit more fatigued, but other than that, about the same.
Thanks, Les. That I was going to ask, is there anyone else that's switched from Lupron to Eligard or Eligard to Lupron that's on the call? Okay. Rich, this is, again, anecdotally from the benefit of experience, this is what I've learned over the last 10 or 11 years, that when one of the drugs becomes onerous for whatever reason, you're getting exceptional side effects. It's not controlling your testosterone as well as it should. Men have tried a different version of the LHRH drug. It's never really been clear to me, as Professor Bill says, why it should make a difference. But there is evidence, and some people will tell you that they move from one to the other. There is a difference. The only drug that seems to have superior performance is the Firmagon, the Degarelix, which again does the same job, but it does it in a slightly different way. It's an antagonist rather than an agonist, and so that's why you don't have to take the buffer meds at the beginning, and that's why some people have started on it and then switched to a different formulation, because the Firmagon Degarelix is more expensive. At the same time, I mean, it's been reported that switching from one drug to the other within the overall LHRH category can help some people. Maybe it's as Bill says, it's in the delivery method. I don't have an explanation, and I've never heard good reason. Len, you're the research pharmacologist in this group.
Well, I agree with what Bill said. It really shouldn't make any difference. The only difference I can imagine that there would be is with regard to side effects, might be that someone might be more sensitive or allergic to one of the matrix components of the depot formulation. Other than that, the the active ingredient, leuprolide, is what causes the side effects, or well, it causes the reduction in testosterone, which causes the side effects. So there shouldn't be any difference. And I think, I forget who, I think someone said they felt more fatigued when they switched from one to the other. Could simply be because they were now on a ADT therapy that much longer. But,
Well, they were older. Well, they were older, and that can make it. That can have
Yeah.
an impact.
Yeah.
All right. So, Rich, do you want to comment on any of that? Ask any questions?
Well, it's, as I've mentioned before, I'm the new kid on the block. I was diagnosed last October. The reason that went from Lupron to Eligard was changed urologist. And the new urologist point of view was it's more cost effective for Eligard. The Lupron shot was a 6-month shot. I broke it down to a 3-month shot for the Eligard. It got the Eligard shot about 3 weeks ago now, and it seems like I'm running into more temperature loss of control and more emotional loss of control. So it's, I understand the chemicals are the same and the delivery method is the difference, but it could be, I'm now pushing 7 months into it, which for some folks here, that's a walk in the park. It's nothing, but and I understand that it's cumulative as well, that the effect of low testosterone is also cumulative.
I'm sorry?
Somebody wanted to respond to that.
I was just going to say, that to you, Rich, that, every person and every body is different. And, right. You could very well be reacting differently in a way that, it would be very difficult to understand just because your physiology is somewhat different compared to others. So, I wouldn't, I think it might be a mistake to think that you're not really having these side effects and that they're not different. But, the bottom line is there shouldn't be major differences in the way that you experience both drugs.
The only way to be sure, Rich, is if you ask your doctor to switch you back to Lupron and see if you feel better.
Good idea. Yeah.
I'll take that under advisement.
So,
and remember, you're the boss. If he doesn't like that, maybe find another oncologist.
Well, no, it's not that I'm having any new side effects. And I guess the question was more, had anyone experienced any major changes in the side effects that they already had that are kind of your basic core side effects from low testosterone, which is the hot flash, mental confusion, the emotional ups and downs, those type things. If there was any, I didn't expect there would be any major changes. I would hope not, because as you pointed out, they are the same chemical. It's simply where the shot goes in and then the time release method for the drug itself.
So, Rich, there's a couple of observations I would like to make.
I think he froze.
Yeah. Rick, we can't hear you. Rich, while we're waiting for Rick to get back to us, one thing that I found, this is Jake. One thing that I found is that some of the side effects are cumulative. In particular, the emotional part of it. The longer you're on it, the longer your testosterone is low, the more likely you are to have some side effects. At the same time, in my case in particular, I found out that some of the side effects got less for me. like the hot flashes, for example. I guess my body got used to it. I've been on it. It'll be 6 years. It is 6 years this month. And so some of them that I had at first no longer bother me, or very infrequently bother me.
Okay.
The emotional thing is that's an ongoing. I think that kind of goes with the territory.
That's similar to my experience too. I had a big problem with hot flashes early on, but now I haven't had one in a couple of years.
Right.
And Rich, I started to talk before, but I guess I lost my sound momentarily. First of all, Lupron is available as a 90-day depot. So there's no reason why your doctor couldn't give you Lupron in a 90-day formulation.
That's one of the reasons I changed urologist.
Okay. Well, again, it's available. I mean, there's no reason why you can't get it as a 90-day shot. Secondly, I probably would be monitoring my testosterone and just see if there's a difference, and whether there's a difference in my testosterone levels now to what it was under Lupron. I mean, that would give you a measure of the efficacy of the drug. Thirdly, I agree with the guys that the side effects are cumulative, and they tend to kick in more after the first 6 months. And so what you may well be experiencing is your journey on an LHRH drug, which is probably going to get worse and worse over the period that you're on the drug. I mean, fortunately, with your situation, you do have a limited time that you expect to be on the drug. But I think you can reasonably expect that the fatigue is going to get worse. The hot flashes could well get worse before they get better, but for some people they don't, like for Jake. They did for me, get worse. They continue to get worse. But you know, the bottom line is I don't know why you just can't get 90-day Lupron. That's what I don't understand. If a guy can give you 6-month Lupron, 180-day Lupron, he should be able to give you a 90-day Lupron.
Did you mention, Rich? I'm sorry,
cynic here. I just want to get this in. I'm sorry to be a cynic here, but you know, it could be that the doctor administering the drug gets a better reimbursement or somehow gets more money, you know, by using one drug or another, one 3-month or 6-month depot. So yeah, if you want 3 months, you should get 3 months. And it bothers me a little bit that you mentioned urologist. I think you should be seeing a medical oncologist, not a urologist at this point.
Well, that's part of the transition as well. The original Lupron shot was from the diagnosing urologist. That was 6 months. I had asked about a 3-month shot. He came back and offered me Firmagon for 3 months. And he said, I can get something in here next week. So at that particular time, just kind of diving in the pool, I turned around, dropped my drawers and bent over, took my 6 months, and then made a determination that I would locate someone else to take care of things later. My current urologist is a oncologist. He's with Urology of Virginia, but is an oncologist. And they use Eligard as a cost, basically due to cost between Lupron and Eligard. And initially they were going to do a 6-month Eligard, and it's like, no, let's do a 3. And they didn't balk too much, but they stopped and looked at me like I'd grown 3 heads, and then agreed that, okay, we'll give you a 3-month shot.
Rich, something else to bear in mind when you're talking about Lupron. You know, we use the terms Eligard, Lupron. you know, kind of like we use Xerox for when we say we're going to make a copy of something. Lupron is now generic. So, you know, if anybody's making extra money because they're selling a brand name versus the generic, you might want to either seriously consider finding a new doctor.
Okay.
Yeah, I would ask your new oncologist why he is using Eligard. And I think it's a good idea that you switch to 90 days too. I started out on 6-month injections, and they ran out of drug, which is something that happens with the 6-month formulations. So about 2 weeks before the 6 months was up, my testosterone would start rising again because the matrix that was providing the drug there wasn't any more drug. And with the 90-day formulations, that happens. What I've been told is that happens. It's much less likely that it will happen. So I think it was a smart move to ask that he give you the 90-day injections instead.
It's Larry Fish.
Go
Hi.
ahead, Larry.
So I just want to weigh in briefly that reminded me of how things started with me originally, and that this talk about doctors going after the way that's most profitable for them, it's not our fantasy. It really happens, and it can easily be that this is the way that's most convenient for one urologist or one oncologist to make more money.
Yeah.
I remember when I went to my original urologist, he tried to sort of dominate the case and prescribed, Casodex and Lupron, and sent me to the oncologist, who said, "Oh no, a medical oncologist," who said, "I have to take over this case. I hate to say it, but it's a matter of money, and the urologist is not the person to be deciding this for you. I am." And later I realized that he gave me those shots in his office himself, and it was to his benefit. And later on I changed it. But there was a lot of issues, but little competition between a urologist and an oncologist about who was going to get more money by giving Lupron shots, which apparently at the early stage of my treatment, that was where the big money was. That's the only comment. That this is not fantasy. This happens, I guess, very frequently.
Oh, reimbursement has been mentioned a couple of different times. My radiation oncologist actually requested the ADT, Casodex and Lupron, and implied in our initial conversations that he would be administering both. And then when it came time to start the ADT, he says, "Oh God, no, they will rip me apart around here. You have to go back to your urologist, and he will give you the ADT. He will give you the shot."
Yeah, and what you're hearing there is the local dynamics between the radiation oncologist and the urologist. And the urologist says, "I'll refer to you, but don't you be giving him the shots, because that's where I get my bread and butter. That's my cash cow." And whilst the radiation oncologist can give it to you and may give you what you want, he's going to cut off his referral source. And again, this is why a lot of times, Les, we say to people, go to a center of excellence, because the center of excellences usually are not driven by financial considerations. So it doesn't matter who gives you your shot in a center of excellence institution. It could be the urologist, it could be the medical oncologist, it could be the radiation oncologist. Doesn't matter. But in a community scenario like Rich is in, the money becomes more important than the patient. And I personally find that I resent that. And,
well, it's not so much the money became ahead of the patient, because I still received the same treatment. It simply was changed who I've been over in front of. So the treatment actually itself was not altered because of the money. And at a certain point, I don't care if I'm paying the oil change technician to change the oil in my car, or if I'm paying a dealership to change the oil in my car. The oil in my car got changed.
I could agree with that to some extent, but another version of the same experience that I had was when I went to, I shouldn't mention NYU, but they were pretty tricky because they managed to change from my medical oncologist giving me the shot to sending me up a flight of stairs to get the shot. I didn't see any difference in how much I paid, but I noticed the billing went from $1,200 to $2,400 for the same shot, and the reimbursement rates. So they were being very clever about maximizing the way they got reimbursements. I don't know how they managed to not get this, but it's a very good idea to maybe take a look at the amount that is being billed and the amount that is being paid to your insurance company, just to see like when a medical center, a hospital, a doctor are really trying to be very manipulative about how they get their reimbursement, because I think it affects the way that they make decisions about what they'll do.
Yeah, and Rich, I would go one step further. You ideally would like to get 90-day Lupron shots from a medical oncologist. That should be your goal. And there's no reason why you can't get 90-day Lupron shots from a medical oncologist. And if the system is forcing you to get something other than 90-day Lupron shots from a medical oncologist, then it does matter who changes the oil.
Rick, can I make a clarification on something I said about the generic part?
Yes.
I think I was wrong. I misspoke. I was thinking of zoledronic acid versus Zometa and zoledronic acid is generic. I'm not sure, and probably Lupron, Eligard probably are not generic at this point. So I apologize for misstating.
But you know, I don't think it should matter that much. From Rich's standpoint, if you're advocating for yourself, you should be able to declare what type of drug you want and who you want the shot from. And if you're having to compromise on that, then you have to take into consideration the reason for that compromise. I think that's what Larry is saying, what I'm saying, and what you have to take into account moving forward.
Absolutely. Yeah.
Okay, I can do that.
Okay, we're going to move on. We've got about 4 or 5 minutes. I want to touch base with Jeff Ledoux, and I want to get an update from Professor Bill for all of you. I mean, I know what's going on with Professor Bill, but I would like all of you to know what's going on with Professor Bill too. So, Jeff, how are you? We haven't heard from you for a while. I have, and I know where you're at, but fill in the guys with what's going on in your world.
I hope my unit, it seems to be working.
Okay.
All right. I was going to be put on Lupron to save me money. And the only problem there was I'm also on denosumab, which is, as you know, Prolia for osteoporosis. Well, I still have to come back every month for the denosumab, and it didn't matter, 2, 3, or 6 months for Lupron. I still have to come back down to the doctor's office. So I said, no, we're not going to change what we've been doing. We stuck with the Degarelix. So I'm still on Degarelix. I'm still on denosumab. I am on, and I went on Zytiga back in October, and instantly my PSA began to ratchet slowly up. May, it was 4.28, and this month on the 6th of June, it came back down to 3.3, which thrilled me anyway, but that seems to be the way the Zytiga is working. We were talking about, what is it, Yonsta, which is a different formulation of abiraterone, or some other changes there. And ultimately, my oncologist said, we're gonna stay the course. We're gonna keep riding this horse and make sure it's gonna keep on working. So there I am. I'm basically stable. I'm up for bone scan, CAT scan, first of next month, but the last ones were all stable. In fact, I had lost one metastasis on a rib. It just was gone.
Good. Now, let me ask you, I know you have some issue. You are on metformin, but you have some concerns about elevated blood sugar. Do you want to ask the guys about that?
All right. When I first went on the Zytiga, I was taking 5 milligrams of prednisone twice a day. My blood sugar by the end of the day, daily, was in the 250 to 300 range. I don't like that. I know what blood sugar will do to kidneys and other organs. So I talked to my PCP and my oncologist, and we all came to one conclusion: reduce that to 1 5 milligram prednisone a day, take it in the evening. And my blood sugar, like this morning, was 93. Yesterday was 96. So it's actually worked to bring that back into range.
Okay, great. Anybody want to comment on blood sugar issues and, when you're on Zytiga and prednisone?
Oh, I am on 2,000 milligrams of metformin a day.
Right. Any comments from anyone?
Sounds like you're doing everything correctly. I mean, Firmagon, there is some solid evidence in the literature that it's superior to Lupron.
Right.
So, for example, it has something called anti-angiogenic activity, which means that it tends to block the development of the blood supply into tumors. And that's good. If they don't have a blood supply, they die, the cells in the tumor. So I think if you can, the downside to Firmagon, in addition to perhaps the cost, is that you have to go in once a month to get the shots. And they also, for some patients, trigger a pretty vigorous inflammatory reaction that really stings for a couple of days. But if you can tolerate that, I think you're, it's good that you're on it rather than Lupron.
Early on, I had some that were like 4 inches in diameter and about 1.5 inches high off of the injection site. So yeah, painful, very painful.
Yeah. But it's worth it. I think it's, I wish I had won that battle with my oncologist back a long time ago.
I did.
I took Degarelix for quite a while, at least 15 months, I think. And I don't know what your experience is, Bill or Jeff, but I found not only did I get the injection site reaction, but I was getting these little fibroids, maybe not so little fibroids, very hard tissue masses underneath the skin in my abdomen. Did you guys get that as well?
I haven't.
One of the reasons why I switched to Lupron.
I haven't had any of that, but I've only been on this for 3.5 years.
Oh, that's a long time.
That's a long time, yeah. And I was only on it, Len, for a couple of months, 3 months, maybe 4 months.
And it looks like I'm going to be on it for a long time.
Yeah. That is something to watch out, though, for, because once these nodules form, it makes it difficult to inject.
Do they go away? The nodules, do they resolve eventually?
No, not in my case.
Huh.
Yeah,
so you have a mini
scar
six-pack in your abdomen.
No, I mean, it's not visible, but on the surface, but if I run my hand along my abdomen and kind of massage, dig in a little bit, I feel them.
Huh. I'm personally, I'm amazed about the prednisone. Cutting it in half reduces Jeff's blood sugar from 200 something to 90 something.
That's been exactly the way it went.
Yeah.
Not that surprising. It's kind of to be expected. Prednisone or any glucocorticosteroid can raise your blood pressure and your blood sugar.
That's a hell of a difference, though.
Oh, yeah.
It is.
Yeah. So
Well, guys, let's because we're just a little bit over time, and this is a great conversation, and I'm learning stuff about blood sugar and prednisone and what have you. So I'm very grateful. But let's switch over to Professor Bill. Before we do that, I just want to give you, Eric Bookbinder was on the call very briefly and then left. But I would like to just give you a quick update because I did speak to Eric over the weekend. He's home. His surgery was successful, which is dynamite. They put in some sort of a metal structure scaffolding to support his vertebrae, and they were able to find places to anchor it. When I talked to him, he was still on medication, on pain medication from the surgery. So it's really too early to tell whether or how successful it's going to be. But I think it was just terrific that he was home, he was walking around, he hadn't driven yet. So I don't know. I'll probably give him a call tomorrow. And it sounded like he had some housekeeping business there to take care of. But I do want you to know that he's doing well. And then the other person who had a hospital visit and a mini crisis emergency, but seems to be doing much better right now, is Professor Bill. And Professor Bill, you want to just fill these guys in on your electrical system?
Okay, I'll make it as quick as possible. So, in a nutshell, early last week, I was having episodes of orthostatic hypotension, meaning that my blood pressure would drop. I was working out in the garden, and every time I stood up after planting something, I'd come close to passing out. So I called my primary care physician and told her what was going on, and she told me to come into her office, and I told her I'd be there in a couple hours, and she said no, right now. And so I drove there, and when I got there, she did an EKG, and then she abandoned a waiting room full of patients who were waiting to see her and personally drove me to the ER. So you can't ask for better service from a primary care physician than that. So basically, we don't know what's going on, but I'm having episodes of bradycardia, so low blood pressure. My blood pressure is bottoming out at about 39 beats per minute, which is not too far above what's required to maintain viability. And we were able to get it back up again while I was in the hospital for a few days. And so now it's up in the 50s beats per minute. And that's enough to release me from the hospital. And I'm planning on seeing a cardiologist tomorrow. The concern is that this is being driven by the drugs that I'm taking in the clinical trial I joined back about 12 days ago. This is cardiac toxicity is frequently a problem with experimental drugs. And I actually, on Friday, I went to a symposium that I organized for 18 years, but not for the last couple of years. And I went to the last session and learned of a talk that had been given the day before about the combination of drugs that I'm taking in my clinical trial. And so I had a really nice chat with a graduate student who gave the talk, and he sent me a PDF of an article about inhibitors of the same type that I'm receiving in this trial. And the first thing that I read was that in about 19% of the patients in the phase 1 clinical trial, they suffered from cardiac problems. So I don't know where I'm headed. I may have to drop out of the clinical trial. I'm be devastated if that's the case, because there's really not that much left to try. But I'm hoping that I'll be able to deal with this enough to, to remain in the trial. So we'll see. So that's my update.
So now you think it may possibly be related to the ATR inhibitor, Bill?
Yeah, I think it was after I spoke with you, Rick, that I learned that this particular inhibitor does have cardiac toxicity.
Mm.
But it's also the case that it's a different type of, it's a prolonged QT interval. And although that was what I was diagnosed with by my primary care physician, that turned out to be wrong. Once I got in the hospital and saw a cardiologist, they told me that it was bradycardia. So I'm hoping that means that, since the inhibitor is triggering a different type of, cardiac problem, that means that I won't get kicked out of the trial. But the bottom line is I'm having cardiac issues. We don't know what's causing them. This drug is known to cause cardiac issues. And so it's, I don't know. Don't know what's going to happen.
I know with Eric, a lot of it was related to his hydration. Is your hydration good?
It is now. It's a chronic problem for me. I'm chronically dehydrated because I'm catheterizing, and it's inconvenient to catheterize frequently. But that's okay. I've learned my lesson, and I'm going to deal with the inconvenience and remain as hydrated as I possibly can. So yes, that is.
Bill, are you taking any kind of beta blockers for your heart, for heart rate?
No.
Or blood pressure?
I was taking lisinopril, although that's not a beta blocker.
That's blood pressure, right?
Right, and I stopped taking it 2 days before I went into the hospital. So that could be part of it. We're hoping that once that washes out of my system, which will take apparently a week to 10 days, that this issue will, will not be as much of a problem. So I'm waiting to see.
Let's hope.
And they didn't give you any medication, right? You're just...
No. They wanted to, initially, they wanted to put me right into surgery and install a pacemaker until they heard the rest of my history and, the fact that I was on this clinical trial. So even they didn't make the connection. The cardiologist I saw in the hospital didn't make the connection to the drug that I'm taking on the trial.
Right.
I did only after I read this
The
PDF that the student sent me, right?
Yeah.
But now I toyed with the idea of just keeping my mouth shut and not telling anyone. But that's not an option.
Bill,
Probably not a good idea.
I'm sorry.
Bill,
Probably not a good idea not to say anything.
Yeah.
I too have been diagnosed with AFib as well as bradycardia. They slapped me on metoprolol and Eliquis to keep my blood fluid moving and regulate my heartbeat. It's now running about 50, 55. Used to normally be around 45.
Okay.
That should help for that.
So I have a blood pressure monitor, and I take I measure my blood pressure a few times a day.
Yeah.
And it's now running from 50 and above. So, but that's probably reflecting the fact that I'm working harder at staying hydrated.
Yep.
So I may be able to stay in the trial. I'm just, if I get kicked out, I'm going to be very,
Right.
very disappointed.
Well, you know what we say about Professor Bill? Takes a licking but keeps on ticking.
He's not the only one.
Yeah, that's for sure. Yeah.
Which is why you guys haven't heard from me. I haven't had anything to say.
Well, that doesn't mean we shouldn't hear from you. We like
Excuse
you.
me?
All right.
No, it's good. It's always, I like hearing from somebody who doesn't have anything to say. I mean, yeah, you should be telling us these things.
That's right. All right, guys. Well, look, we're 15 minutes over. I'm sorry. We started off with a small group. We finished up with a big group, and I try to make room for everybody who comes in later. So for those of you who did arrive later, we talked about the ASCO observations early on. Sorry that Bill wasn't on there because he could have elaborated on a few of the comments that we made, and he'll have to listen now and tell us how we blew it.
Yeah,
Or where
I'm
we
sorry.
do it.
Yeah.
But that's okay. We can always come back when Bill's on the phone and revisit the abiraterone and olaparib on recurrence trial. But right now we are tapped out. So next meeting is the 18th, right? Is that right? Sounds right to me. Monday the 18th. It will be the third Monday of the month.
Yes.
Third Monday of the month. And just one other thing. Just this is totally, it's an ANCAN thing, but it's very personal. I am absolutely thrilled that as of this morning, we set a date to start a new virtual group for brain tumors, which has been on my list for quite some time. And I think we found two fabulous moderators, and it's very exciting. It's always exciting to me when we can start a new group. So God forbid any of you know people that are dealing with any type of brain cancer or caregivers. We have a group coming up for them in the not too distant future.
That's
Okay.
terrific. I'm glad that you're able to start that group. I'm curious, Rick, by brain tumors, are you including benign tumors in addition to malignant?
It's totally up to them. It's totally up to the moderators. Okay. They will decide. I've left it with them how they want to define their group, whether it's just glioblastoma, whether it's all types of malignant tumors, if it's malignant and non-malignant tumors. Is their call 100%.
Okay. I hope they include non-malignant too, because they're fairly common and they're just as deadly as a malignant tumor in the brain. So, but anyway, congratulations. I'm really glad that you were able to get that going.
I will pass that feedback along at the appropriate time.
Okay, great.
Thank you. Okay, but guys, I will say goodnight to you all and speak to you next week.
Have a good 4th of July.
Good night, all.
Yep.
Good night, everybody.
Good night.
Good night.
All right.